जी अस्सलाम वालेकुम।
जी वालेकुम सलाम सर, खैरियत से जी?
क्या है नाम? ठीक ठाक।
अल्हम्दुलिल्लाह, अल्लाह का शुक्र सर।
अच्छा जी, is Dr. John here or no?
No, he's not here yet. I have emailed him. Uh, Dr. Shazad is here, who's one of the speakers from Beria Town Hospital.
Dr.
And
Assalamu alaikum.
Assalamualaikum. Yeah, I think वो हमने सारों को म्यूट ऑल किया हुआ था. He's currently mute. Dr. Nayyar के बारे में हम बात कर रहे थे earlier, who worked in Canada and has done a bit of PD there. He's just joined in as well. So yeah, we still got still 5 minutes. Hopefully, Professor John will. Yeah. Oh, okay. So he's emailed and he's saying that I'm here. We'll sign on in a couple of minutes. Yeah. डॉक्टर शहजाद, आप मेरे ख्याल है बोल रहे हैं, आपको शायद म्यूट हुए हैं शायद आप, इसलिए शायद आपकी आवाज़ नहीं आ रही. हाँ, आपकी नहीं आ रही आवाज़ मेरे
आप ही
ख्याल है.
अनम्यूट करेंगे?
हाँ, नहीं देखिए ना, हाँ बस वो मतलब हम लोग खुद एक्चुअली जान के म्यूट किया हुआ है ताकि वो, बट वी विल बी म्यूटिंग एवरीवन. वो जब ज़ाहिर है व्हेनेवर यू गॉट टू टॉक यू विल हैव टू प्रेस म्यूट, अनम्यूट करना पड़ेगा, लेकिन वो ताकि हर एक टाइम पे सारे ना बोलें, इसलिए वो ये फीचर लगाया हुआ है. इज दैट ओके? या ठीक. हाँ हाँ.
अच्छा जी, आवाज़ आ रही है मेरी सही?
या परफेक्ट सर, एब्सोल्युटली लाउड एंड क्लियर.
अल्हम्दुलिल्लाह. तो अच्छा जी,
Good morning, Professor Crabtree. I'm sorry. I think I've muted everyone, so I think you're all still on mute.
आप कर दें, अनम्यूट कर दें.
Yep. We can. Can you hear us?
Good evening. I can hear you well.
Okay. Excellent. Thank you so much for sparing time. I know it's very early. I think we early is in the AM, isn't it? So thank you so much for sparing time.
Morning. It's good. Yeah. You know, surgeons get up early. It's good to see everybody.
Thank you so much.
So, sir, it's a pleasure. I'm Dr. Noman Tarif, and I'm so thankful, and I just want to say that I just can't explain how quickly you responded and agreed to the to this webinar, and it shows that you are up for help for anytime, anywhere, and that's a great thing. We have gone through your articles all along. I think everybody must have, and I think it's an honor to see you here and be part of this webinar.
Well, thank you, Dr. Tarif, and I'm certainly glad to be a part of this webinar, and I think all of us are very concerned about the special types of patients. So I think that explains some of our excitement about taking care of things like this.
Excellent.
So I understand that we're going to have some case presentations. Is that correct?
Yes, absolutely. Sorry, I think I didn't introduce myself. My name is Ahad. I think we were in conversation with each other over the email, isn't it? So,
Yes.
so the way it's going to work out is that initially I'll just sort of introduce you and the three speakers who will be presenting their cases, and it's just going to be sort of like the problems we faced, what we did, whether it worked, whether it didn't work, and then we'll come back to you and ask that what do you think we should have done, or what do you think you would have done in if you were in our situation, considering that we are to a certain extent a resource limited country. And before we start the case presentations, I'll give you we'll give you the mic for you for 15 minutes. So if you want to talk about anything or what I did send you the program earlier, and maybe we can address in your opinion just the sort of basics, if you can identify those, that who do you think should be putting PD catheters in, and and if, let's say, if it is going to be a nephrologist, in your opinion, what should be the minimum amount of expertise that one should have, or do you think that that's not necessary at all, anybody can do it? The reason being is that some of the delegates who have joined in are very excited to start. Well, the main intention is that they do want to start PD at their own centers, and they do have the initiative, they have the motivation, but they're just sort of worried whether they do have the expertise, yes or no. So yeah, a lot to take in, but we look forward to hearing from you on that part as well.
You bet. And when we did communicate previously, you mentioned that primarily the catheters were being placed percutaneously and by open dissection, and rarely by laparoscopy. You may mention that primarily this was done by interventional nephrologists, I think. Is that correct?
So,
okay.
Some are placed at our center. We usually ask the surgeons to place it. So one of our surgeons is going to present one of the cases. Dr. Shehzad Ashraf is here. We also have a professor of surgery. I did see Professor Farouk Afzal's name probably here pop up as well. So we do have general surgeons putting them in. We do have quite a few interventional nephrologists who are putting them in, but very rarely do interventional radiologists do it in Pakistan. Yeah, and
yes.
yeah.
I think the advantage of the interventional nephrologist placing the catheter is that many times there are surgical backlogs, or there are problems of having operating room access. And so it's very beneficial if the nephrologist can place the catheter. They can do it in a timely fashion. That's important. And I think what's really important, though, is that they do have adequate training prior to that. And I think that would include hands-on training and mentorship by somebody who's already placing catheters. I think that that aspect is important. Here in the States, we have surgeons, interventional radiologists, and interventional nephrologists placing catheters. And this has really become important during the COVID-19 pandemic because of problems of having operating room access. And so we've obviously been challenged by trying to keep up with the training of our interventionalists so that they can be confident and about placing catheters and have good outcomes. So I really think that, it's really a multidisciplinary approach with regards to who's placing the catheters. But I do think that the experience and training is very important.
Excellent. So thank you so much for your thoughts, sir. I was just wondering, do we have a sort of like a PowerPoint presentation from your side as well, or no?
I do. And what I did,
excellent.
because I knew you were doing some going to do case presentations, so I kind of just lined up a few things in order to respond. But what I can do is go through some best demonstrated practices that are applicable regardless of the catheter implantation approach. Do you think that would be of value?
I think so. Yeah, absolutely.
Okay, so let's see. We'll need to share screen then.
Yeah, no. So what I'm going to do is just I haven't formally started the thing. I'm just going to start it in 2 minutes time. Let me just sort of So just give me 1 minute. Let me get rid of my son.
Yeah.
I'm sorry.
And then what I did also is just prepare some potential information that might be appropriate for whatever complications that you plan to spring on me with these case presentations. Okay?
Yeah, absolutely. If I think I've got quite a few people here, so I think we'll just start. I don't think there's no point in waiting. I think we should be, we should go ahead. Okay.
Okay, so
there we go.
we'll
Okay,
share.
right. So no. So let me just sort of welcome everyone in. Is that all right, sir? So just let me just set a few ground rules so that everybody's up to speed. That's how it's going to work out. Right. So Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. So a very, very good evening to everyone and to Professor Crabtree. And I see Dr. Kamar Khan from the US who has already joined. So a very, very good morning to you guys. It's truly a distinct honor and privilege to welcome you all to this webinar, wherein we will be discussing PD catheter placement and the associated issues tailored to the needs of Pakistan as far as peritoneal dialysis is concerned. You may have already noted that this is going to be more of a case-based discussion, wherein 3 cases will be presented, one by an interventional nephrologist, one by a nephrologist, and another one by a general surgeon. And they're just going to describe what they did, what sort of problems they ran into, and how they did their troubleshooting, and we'll sort of take it from there. I do want to welcome everyone individually, but I think that will take too much time. So I would just like to sort of thank Professor Crabtree more than anyone. He is a household name in Pakistan as far as peritoneal dialysis is concerned, and globally as well. The resources, the PowerPoint slides that you have made, sir, I think we have been sort of stealing from them and using them since time immemorial, that what PD catheter length should be, where the cuff needs to be. We've got those in every presentation we give to our residents. There is always at least one slide that at the right at the bottom, there is your name is there, sir. So from the last biography that I did read, so you're a visiting faculty at UCLA and the program director for PD University for surgeons in the North America. And I would just like to at this point introduce that we are using the platform of Pakistan Society of Nephrology and the PD Academy of Pakistan, which is actually a totally pro bono effort where like-minded nephrologists want to promote peritoneal dialysis and give it access to all patients across Pakistan. So I welcome you all, and the floor is handed over to Professor John Crabtree, sir.
Okay, thank you. So we need to share. It looks like we need to share the screen a little bit.
Yeah, absolutely.
Yeah.
So I've allowed you to share it. Can you share?
Here we go. Okay, let's see what we got here. So I'm just going to ask if everybody can see the slides.
No.
No. Okay, so we're obviously not sharing. And so let me try this again.
Yes, now it's sharing, yeah.
Okay, so I'm looking to see how we can bring up my slides here.
Sure.
Well, it looks like we're having a little bit of problem here with the getting the proper slides up. Screen, whiteboard.
There's usually a green button down there.
Yeah.
Yeah.
Now,
here we are.
Is this?
Yep. Yeah, we can share slides. Yeah.
You can see it now?
Yep, absolutely we can. Yeah.
Okay. So what I've done here is this presentation can go any which way you guys want to go with it. I've got a number of topics that are kind of pre-prepared that we can pursue based upon your interest. But we'll go ahead and start off with best practices, which are really things that are applicable regardless of what type of catheter implantation approach that you're using. You know that a lot of our patients are bothered with constipation issues, and constipation is one of the most common reasons for perioperative catheter flow dysfunction because of crowding of the catheter tip in the pelvis because of the distended rectosigmoid colon. Many times, at least in our population here, our surgeons kind of overlook doing bowel preps prior to catheter placement. And this, of course, postoperatively, the PD nurses face with a lot of problems of trying to sort out whether this is a catheter-related problem or a constipation issue. And patient ended up getting a lot of x-rays and back and forth to the PD clinic. So I think it's really important to anticipate that the patient may have constipation issues because of their phosphate binders, iron therapy, calcium channel blockers, antidepressants, or maybe even opioids. And so we do put our patients on a bowel prep prior to the procedure. I think you can use whatever you want to. All of us know that we want to stay away from phosphate and magnesium laxatives, but anything else is pretty well good if the patient complies with it to eliminate any rectosigmoid distension. We do have our patients shower on the day of surgery with a chlorhexidine soap wash as a first step in reducing the bacterial count on the skin. Just another step to try to reduce perioperative exit site infections or peritonitis. If the patient is real hairy, we actually would prefer the use of electric clippers as opposed to a prep razor, so we can avoid nicks and scrapes that can harbor bacteria. And then, of course, we have the patient empty their bladder before they go to the procedure room or operating room. Otherwise, we decompress the bladder with a Foley catheter. And we all recognize it's very important for all of these patients to receive a single preoperative intravenous dose of a prophylactic antibiotics to provide for antistaphylococcal coverage. So that's our preparation of our patient. Let's talk about best practices for the implantation procedure itself. I think it's really important to select the most appropriate catheter type. Many times we only have one catheter type in our facility, and the access operators faced with trying to fit one catheter type to all of our patients. So we do advocate, examining the patient far enough in advance of the procedure that if you need a special catheter type, you have time to obtain one prior to the catheter placement procedure. Avoiding skin creases and folds, avoiding the belt line, and then, of course, if the patient is incontinent of urine, certainly we want to make sure that we have a catheter that can achieve an exit site remote above the level of the belt line to avoid problems with that. We do advocate that the catheter have 2 or more cuffs. When I say more cuffs, we use extended catheters for pre-sternal or upper abdominal exit sites, and many times those will be equipped with 3 cuffs. But we do think that 2 cuff catheters should provide for the better stability of the catheter, as well as the superficial cuff. If it's properly placed, it does serve as an effective barrier to entry of cutaneous debris and bacteria into the tunnel tract. And then before implanting the catheter, I think it's important to rinse this catheter off in saline. Sometimes there are particulate matter left on the catheter from the manufacturing process that can induce kind of an inflammatory fibrous reaction in the immediate postoperative period encasing the catheter. That's very frustrating when you run into that. So we've been able to kind of reduce that by making sure we rinse off the catheter. And I think it's also important and flush the catheter, and then to submerge the Dacron cuffs in saline, milking the cuffs between the fingers to expel air that's trapped in the Dacron, so you have more rapid tissue ingrowth and fixation of the catheter. And then, of course, a lot of times we will use midline catheter insertions, but we know that the risk of pericatheter leakage is lower if we do a paramedian approach through the body of rectus sheath and muscle. This also provides for better immobilization of the catheter and prevent things like catheter tip migration. So we do advocate a paramedian approach through the rectus sheath and muscle, going through the medial portion of the rectus sheath and muscle, because the inferior epigastric vessel trunks are coming in from lateral. So we'll usually go about 3 centimeters off the midline, and that'll keep you in the medial portion of the rectus sheath. And then the deep cuff, we think, should be in the rectus muscle fibers. That will provide for more rapid tissue ingrowth. This is really important if you're going to have urgent starts. Having it in the muscle fibers will help reduce the risk of pericatheter leaks with urgent start. And then the catheter tip should be in the pelvis. One of the problems we have is that many times we get overzealous about wanting it to be deep in the pelvis, and we actually implant it too deep in the pelvis. And this can result in pressure discomfort that the patient feels in the anal genital region. It can result in early termination of dialysate outflow because of the collapse of the bladder and rectal tissues or the uterus against the side holes of the catheter if it's wedged too deep in the pelvis. And then it can be a cause of end of drain pain. You probably don't have a lot of patients on automated peritoneal dialysis, but when you do, you have hydraulic suction that can actually aggravate the problems with end of drain pain. So how do we avoid having the catheter tip implanted too deep in the pelvis? What landmarks do you use? Well, unfortunately, if you use the umbilicus as a landmark and you're using a midline infraumbilical approach, that does predispose to the catheter being implanted too deep in the pelvis if you haven't taken into account the dimensions of the catheter tubing. So what we found is useful is just if you're using a coil tip catheter, aligning the upper board of the catheter coil with the upper board of the pubic symphysis bone while the patient's lying completely flat and marking the upper border of the deep dacron cuff. That's where you'll make the skin incision to intercept the musculofascial layer above the proper distance above the pelvis. And so that the end of the catheter tip is actually in the upper part of the true pelvic bowl. If you're using a straight tip catheter, we take a 0.5 centimeters from the tip of the catheter, and that's what we align with the upper border of the pubic symphysis. Now, this slide shows several things that can actually be produced or simulated with any catheter implantation approach that will help to reduce the risk of pericatheter leaks. And this is really important especially if you're going to be using that catheter within the first 14 days. First is that we're talking about a perimedian approach to the body of the rectus sheath and muscle. That's number one. And number two, you can simulate some degree of rectus sheath tunnel with open surgical dissection. You can do it with percutaneous needle guide wire, and you can especially do it with laparoscopic approaches. So if you have a long rectus sheath tunnel, that will help to reduce the risk of pericatheter leakage. It also eliminates pericatheter hernias. And you will, if you do an adequate length of tubing in the rectus muscle, you will not experience catheter tip migration. The third thing is to have the deep cuff in the rectus muscle fibers, as I mentioned, for early tissue ingrowth. And then fourthly, having a purse string suture. If you're doing percutaneous perimedian approach, you'll be putting a purse string suture in the anterior rectus sheath around the catheter. If you're doing an open surgical dissection, the purse string suture will be at the level of the peritoneum and posterior rectus sheath. But all of the four of those elements can be produced regardless of what implantation approach, and it will reduce the risk of pericatheter leakage, prevent pericatheter hernias, and reduce catheter tip migration. Continuing with the best practices for the implantation procedure, the skin exit site should be either directed downward or laterally. There have been randomized studies showing no difference between the risk of exit site tunnel infection or catheter infection related peritonitis between a downward and a laterally directed exit site. What we want to avoid is these upward facing exit sites, which can pull cutaneous debris, shower water, perspiration, and lead to increased risk of exit site and tunnel infection. And then when we tunnel the catheter, we should use a tunneling stylet that does not exceed the diameter of the catheter. In North America, all the three catheter manufacturers produce a version of the Fowler stylet, but sometimes we can just borrow a trocar from a surgical drain set and accomplish the same thing. And some companies will produce plastic tunnelers as well. The important thing is not to be shoving a big hemostat clamp through the exit site to pull the catheter out through that location, because that can stretch out the skin and lead to increased risk of exit site and tunnel infection, because we want the smallest skin hole possible around the catheter. And then the exit site should be at least 2 to 4 centimeters beyond the superficial cuff. Catheters with a preformed swan neck bend, where we're not concerned about shape memory resiliency forces, we usually make it 2 to 3 centimeters beyond the superficial cuff. catheters with a straight intercuff segment that we've gently bent to produce more of a laterally directed exit site. We make that distance a little bit further so there is some straightening of that catheter in the tract. The superficial cuff will never come close to the exit site. And then we should never be using anchoring stitches at the exit site. That's one of the things that we have problems with our surgeons here. They treat the PD catheter sometimes like a surgical drain, and they put a big retaining stitch at the exit site. And of course, we all know that this can lead to early exit site and tunnel infection. And so, the catheter can be adequately secured with things like benzoin or mastisol and steri strips, and covered with a large enough barrier dressing that it participates in immobilization of the catheter. And then we encourage our access providers to go ahead and attach the transfer set at the time of the implantation procedure. This helps the PD nurse who otherwise would have to go through a multi-step process of sterilizing the tubing to open it up to attach the transfer set. So it should be attached at the time of the procedure, secured to the skin, separate from the main dressing, so they have access to it for flushing without disturbing the main dressing. What you saw here was a semi-permeable plastic dressing. This is not Tegaderm. It's one that's water vapor permeable, so you don't build up fluid underneath it. But we think that probably even a better dressing is one that's completely unocclusive, like just sterile gauze and tape. And so that's what we actually use. So that's kind of a brief run through of some of the best demonstrated practices that, as you all recognize, it really is a constellation of details that we have to pay attention to that will help assure the long-term satisfactory outcome of our implanted catheter. So we can stop here and go to whatever next step you would like to do.
So thank you so much, Prof Crabtree. I think if it's all right with everyone, let's move on with the first case. Is that all right? Can we move with the first case from Professor Nouman Tarif? Because I think, we will definitely come back to a few more things from you. We need your views on a couple of things, so we'll have to come back to you. Is that all right, sir?
Perfect. Yes.
Sure. Okay, Professor Nouman Tarif, you've got a case for us, sir?
Okay, can you see my screen or no?
Not at the moment, no.
Not. Okay, let me see. Share. Allow open Zoom to share your screen. Open system buttons. Just once. I think I have to. Once. Okay. Can you see my screen?
Yeah, we can see your
Yes.
screen now. Yeah.
So the first case is it's a 15-year-old young boy, and he has a Corton syndrome with some deformities. He was referred from a peripheral hospital for continuation of dialysis. He had like 2 sessions of dialysis before, and through the right IJ catheter. And after the second session, it was not functioning. And they were like, his weight is about 45 kg and height about 5 to 3 inches. And so when he came to us, we did an ultrasound, and we saw that there is a clot within the internal jugular vein. And so we had to remove the catheter. So we initiated the dialysis with the femoral catheter and advised PD. And luckily, the father agreed to that. And after 2 sessions of hemodialysis, we put a CAPD catheter. The reason was, he wanted to have, we wanted him to be on anticoagulation for long term for his clot in the neck. And so that was the reason the hemodialysis, fistula, and all these things was like a little too much for this young boy. So we put the PD catheter in, and initial drain was fine. And what we did was, this is from your one of the articles, Dr. Crabtree, and so we had the catheter. The inner side was somewhere over here, and then the exit side, and so we were quite hopeful that it's going to work. The next day, we wanted to do a flushing of the catheter, but unfortunately, it so it was not working. So the X-ray showed that this is the catheter. This is somewhere here is the exit side. It's just going in, and this is the entry side into the peritoneum. And the whole catheter was kind of uncoiled. So it was basically a coiled catheter about 62 centimeter. And so there was no outflow. So we said, okay, what to do? So on the day later, what we did was from the entry side to the rectus sheath, we pulled out the catheter, and we just put it in with the help of a stiff wire. And during the procedure, the inflow outflow was very good. So we were quite hopeful that now this time, we are inside the pelvis and it's going to function. But when we did the X-ray, the catheter was still on the upper side, but it was coiled now and more in its natural curve there. So we said, okay, let's see the next day what happens. So the next day, we did the inflow and outflow. It was quite good. So 500 in, 500 out. There was no issues there. So we said, okay, if the catheter is functioning fine, so let it be there, whatever position it is right now. And let's just continue the peritoneal dialysis. And later on, if we need to do anything, then we can probably change the catheter itself. So it worked fine. And he went back to his periphery. We taught him well. And his father was doing the procedure for him. So 4 weeks ago, this is almost like almost 3 months later. So he had been doing all this dialysis, 3 bags per day, 1500 ml, because of his small abdominal cavity. He could feel, more beyond the 1500. So the inflow is like 5 to 7 minutes. Outflow is mostly like 20-25 minutes. Occasionally, sometime it goes up to 45 minutes. So we did a PET test, and he was a low average in his PET test, and his KTOV was quite good. And somewhere around 0.4 was from the residual renal function. So he was still maintaining his residual renal function. And so we did an X-ray again at the time when he came to us. The catheter was still, high up, but it was functioning fine. So we said, okay, we'll just let it be where it is, and we'll continue this procedure as it is going through. And what we thought of maybe, because we didn't have much of a catheters, and it was a 62 centimeter catheter, the size was a little longer for this young man, and so it had pulled up there. So that's the end of the case, and I would like to have comments from Dr. John Crabtree, please.
Okay, very good. Interesting case. On this, let's leave this last X-ray up if we can. Sure. It doesn't really look like I see a lot of fecal modeling there that would have displaced the catheter. It's kind of interesting that the catheter has maintained this position in the left lower quadrant in this bent situation. It looks like it's more in a position of stress than you would think of as straightening due to shape memory resiliency forces. Was the patient having any pain with inflow or outflow with this position?
No, not at all.
Oh, perfect. Good. And so certainly if a catheter is working fine and it's not really in a satisfactory position, I would still keep it regardless of where its position is. I don't think we have to feel obligated to put it back in the pelvis if the catheter is working fine. But I know that you mentioned that you have some episodes where the drainage was like 45 minutes or what have you.
Sure.
I think because it's a 15-year-old, probably small in stature, you remember how I mentioned about how to line the catheter up on the abdominal wall to determine the insertion point? That would prevent having excessive catheter in the lower abdomen, especially since this is a 62-centimeter catheter in a 15-year-old kid. If you were having problems, persistent problems with pain that was interfering with his dialysis, or he was having flow pain because of the location of the catheter, what we would typically do, if you had access to laparoscopy, would be to position the catheter back in the pelvis and use a suture sling around the catheter in the lower abdomen. I would not stitch the catheter tip to a pelvic structure, but I would use a suture sling around the catheter. I have a picture of that if we want to get into that later. That would help keep the catheter oriented toward the pelvis. So first thing would be to properly align the catheter on the abdominal wall to determine the proper insertion site. And then if you had persistent problems with the catheter being displaced like this, then using something like a suture sling to keep it oriented toward the pelvis.
Do you want to share your the slide for the suture sling now?
Sure. Okay. And so here we go with the, okay. This will stop other screen sharing. Yes, okay.
Yes, I did.
All right, very good. And then let's see if I can get back to mine without causing a lot of problems here. Let's need that. Let's go to this one here. Let me this up, and then let's look at tip migration. Is the screen showing everybody?
Yes.
Yep.
Perfect. Okay, so one of the things that we see with catheter tip in a position of suboptimal position is a lot of times is that the catheter has a shape memory of wanting to be straight, and we've bent a straight catheter to assume a pelvic orientation. That, of course, is not the situation in this particular case, but this is usually what leads to catheters tips migrating into a position of poor function. But again, this is not the situation in Dr. Sharif's case. But what we would do with a catheter, this is a catheter more like what you were seeing, Dr. Sharif, in your patient. This catheter had kind of a shape memory of being in this position because we think it's the way it was packaged. Just had this bend in it, and it just wanted to bend back into the left lower quadrant. And so what we did was just go in the lower abdomen and laparoscopically put a sling around the catheter, as you see here in the middle section, and here this particular patient, and that kept the catheter oriented back toward the pelvis. So it's just using like a 2-0 Prolene suture laparoscopically placed around the catheter. One of the things we have to be careful about is not tying that suture too tight. This is a situation where somebody tied it too tight and crimped off the catheter. But this is a way to take care of the problem. Now, I mentioned briefly how you can prevent catheter tip migration. We talked about rectus sheath tunneling. And I know that you don't have a lot of access to laparoscopy, but basically we can do a laparoscopic approach that provides for a tunneling of the catheter sufficiently that you will not get that it'll be impossible for that tip to move out of the pelvis. And the video just shows that. Here we're just injecting some local anesthetic through the abdominal wall. That's about 6 centimeters below our insertion incision. That's our target. And then we're using laparoscopic port to come into the rectus sheath, sliding it down the rectus sheath, past the arcuate line into the preperitoneal space, and finally into the peritoneal cavity. And then once that's in place, this insufflation needle is removed, leaving this expandable plastic sleeve behind to allow insertion of the laparoscopic port. And then once that's in place, the dilator of the port's removed to complete the rectus sheath tunneling. And I did mention that you can mimic a little bit of this with open surgical dissection and somewhat with percutaneous approaches as well. But then once you put the catheter through here, because it's in that long rectus sheath tunneling, it will not migrate. So I showed you two things there. using the suture sling to keep the catheter oriented toward the pelvis, and then how to prevent it with the initial catheter implantation by using some form of rectus sheath tunneling. So we'll stop there and take any questions or comments.
So I do have a comment on this one. I was just wondering, we're doing a lot of laparoscopic procedures anyway, laparoscopic cholecystectomy. Is laparoscopic PD catheter placement very difficult? I mean, we've got Professor Farooq Afzal and Dr. Shahzad Ashraf due to speak as well. It just may not be a question directly to Professor Crabtree, but if Professor Farooq Afzal can sort of comment on this, can he? Is he there?
Dr. Farooq?
Yeah. Okay. Yeah. Can you please repeat the question?
So the question is that clearly what Professor Crabtree is sort of suggesting is that if we place the PD catheter in place laparoscopically, there's a less chance that the PD catheter would migrate. We could use this 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 loop sort of suture, and it won't migrate that easily.
Yeah, absolutely.
Is there
I agree.
Is there a reason? Because to the best of my knowledge, we aren't doing that in Punjab or Pakistan, or are we?
No, we are doing it. I mean,
Okay.
this is the standard technique which we use, that we tunneled it. The problem is that sometimes you need two telescopes for that. So you need a 5mm telescope as well as a 10mm telescope. So sometimes you are like lacking that 5mm telescope, so you have to use two 10mm scopes, and that's why sometimes you just do it blindly. But otherwise, yes, we do it, and we always bury this cuff into the rectus and close it with a purse string. I don't know. I don't try it from the inside because it's technically a little bit challenging to purse string from the inside. But we do it when we are closing the port, so we do it externally. And the second, sling, yes, sling is another way of maintaining the position of the catheter. And we also use this Prolene sling. This is a great way of making sure that the catheter doesn't move.
Okay. No, excellent, sir. Okay. Great.
Yeah. Are my slides back up again?
Yes, sir. Yeah.
Okay. So I just want to make mention, Dr. Farooq mentioned using 2 ports. So actually we only end up using a single port. So here we see the port in the rectus sheath tunnel with the PD catheter going through, and we just have a single 5mm port on the other side monitoring the process. So it can be done with a single laparoscopic port. And see, that just guides you insert the catheter through that rectus sheath tunnel port, pull the stylet back, the coil tip is positioned in retrovesical space. And that will, allow you to implant the catheter. There's the deep cuff, pulling it into the rectus muscle. So it can be done very easy. I think that it probably is underutilized, but I think as we become more comfortable with laparoscopy, like you're doing laparoscopic cholecystectomies and laparoscopic appendectomies, probably, there's no reason why we shouldn't be doing more laparoscopic catheter implantations. There are other things that can be done.
John,
yes.
Yeah, John, my question is, do you use any purse string from inside to the peritoneum?
Do not. No, our purse string suture, Dr. Farooq, is on the outside. I'm going to try to get back to that slide. So when we do it laparoscopically, our purse string is on the anterior rectus sheath here, because you don't see the posterior rectus sheath here at all from the outside. So we place the purse string suture through the insertion incision on the anterior rectus sheath. And it's just a simple box stitch. And we use like a UR6 needle, which is a nice needle that will fit easily through a small laparoscopic incision, and it won't bend. The other advantages of the laparoscopic approach, of course, if you have redundant omentum, you recognize it at the time of the procedure. You can stitch up the omentum so you can avoid omental entrapment. Or if the patients have previous peritonitis or previous surgery and has adhesions, laparoscopically, those can be taken down. Sometimes we have to resect the apoploic appendices of the rectosigmoid colon because they can be redundant. And when we do the catheter flow test, they siphon up to the catheter and obstruct the side holes. And sometimes we have redundant rectosigmoid colon that we can stitch up to the side wall to open up the pelvic inlet. And then the last thing is that laparoscopy allows you to diagnose and treat previously unsuspected abdominal wall hernias. So all of these are advantages of using a laparoscopic approach, being able to perform these adjunctive procedures to avoid the most common mechanical complications.
May I ask question to Professor Crabtree, please?
Yep. So can you introduce yourself? Is this Shehzad Ashraf? Is that right?
Yes.
Yeah. Okay. So this is Dr. Shehzad Ashraf. He's the general surgeon at Peritown International Hospital, and he helps us do our PD catheters. Yeah. Should go for it, sir.
Great.
I would like to share this screen with you.
Oh, so are you going to present your case then?
Yeah, sure.
Oh, okay. So just give me just hang on, Shehzad, just for one sec. Any other comment for the first case, or can we move on?
So one question from Professor Crabtree. Sir, please welcome to you. As already you are welcome, Professor Crabtree. If we are using a perimedian approach and patient has already peritonitis and the peritonitis fluid spills into the rectoid muscle, is there any chance of any disadvantage of using this perimedian approach?
So you're concerned about the adhesions to the abdominal wall and going through there and possibly having bowel injury? Is that the concern?
No. My concern is that if there is any patient has already got intra-abdominal infection, or if we are using tunnel approach, perimedian approach, and patient patient gets peritonitis during the course of treatment, isn't it the source that the infected material will spill into the rectus muscle? Because we are going through the rectus sheath and rectus muscle, right?
Yes, so you're concerned about if they have a peritonitis that they're going to have an infection in the abdominal wall, in the musculofascial layers. Is that the concern?
Yes, sir.
Okay, so I really haven't seen that. Obviously peritonitis is a very common thing that we have to deal with, and I've not really encountered any abdominal wall abscesses as a result of the catheter passing through the rectus abdominalis muscle. Fortunately, the rectus muscle is very vascular and usually very resistant to infection. So that really hasn't been an issue.
All the talk, but I was just curious about that urokinase that we use for permanent double lumen catheter, and we use that to open for any clotted permanent double lumen catheter. Can we use that in a clogged peritoneal catheter too?
Okay, so can we repeat the question then? I'm sorry, the audio is not optimal.
All right. So for a permanent double lumen catheter that we usually place back in Pakistan, we usually have a urokinase that we use for thrombolysis. So can we use the same in that clogged peritoneal catheter?
Yes, urokinase can be used in the peritoneal catheter.
Okay, right. Excellent. If there are no more questions, can we move on to the last case? Dr. Haroon, the floor is yours. Are you there?
Yes, I'll just share my screen.
Okay, so Dr. Haroon Ayub is an interventional nephrologist. He's trained in the UK and is putting PD the catheters in under fluoroscopic guidance at Evercare Hospital, Lahore.
So thank you, Dr. Ad. All right, so thank you, Dr. Ad. Assalamu alaikum, everybody. So can you guys see my screen, please?
Yes. You can maximize it.
Yeah. Okay.
There you go. Perfect.
Right. So I'm going to present a case of a 35-year-old gentleman who presented to me for PD catheter insertion. He was in maintenance hemodialysis thrice weekly at home. He had a previous history of having a transplant which lasted for 10 years. At that point in time, the patient wanted to switch to peritoneal dialysis just because of his work. He wanted to travel a lot in Pakistan, so he wanted to be a bit more mobile with regards to his dialysis. So he wasn't having any problems with his vascular access. He had a functioning AV fistula, but he wanted to switch to PD. His height was 5 feet 4 inches, about 50 kg of weight. So ideally, this patient should have a 57 centimeter tank of catheter, but because of the availability, so I use a tank of swan neck coil tip double cuff catheter, 63 centimeter in size, which were inserted on the 28th of April this year. So this is set that is normally used. So preparation. So a subumbilical incision was given. So dissecting out, we're using both forceps to pull up the anterior rectus sheath, and then injecting dye and make sure that it's in the peritoneum. So you can see that the dye, it's moving around the gut to make sure we're not inside the gut. Then using Seldinger technique, while inserting inside the peritoneum, then the dilator. So this is the dilator with the peel away sheath, and this, inserting the catheter without the peel away sheath. And this was the original position of the catheter. Nice inflow and outflow. So the patient was with me for the next 2 weeks with daily flushes, good inflow and outflow. And then he was started on dialysis, 3 sessions a day, presented with problems with outflow, no problem with inflow on the 25th of May, about after a month. So you can see that the catheter had migrated upwards. So no problems with the inflow, but problems with the outflow. So what I did was I then manipulated the catheter laparoscopically using a stiff bougie. So this is the video of migrating the catheter. So I dissected out the deep and the superficial cuff, and this bougie was used to manipulate and the migrated tip of the catheter. So it did have some of its memory, so it would coil around itself. So I did use some of the time to make sure that it was in the correct position. At this point, the catheter is curving around on the upside. So I wanted it onto to the other side. This was the final. So I was happy with this position. So you can see the catheter is now again placed inside the pelvis. And at this point, the patient had good inflow and outflow, no problems with inflow outflow whatsoever. So this was the X-ray after this procedure. You can again see that the catheter tip is nicely placed inside the pelvis. So again, about after 1.5 months of good peritoneal dialysis, good inflow outflow, the patient again had problems with the outflow, no problems with inflow again, but problems with outflow. So at this point in time, you can see that the catheter has again migrated up inside the abdomen. So you can inflow, there's no problem with inflow, but you can't drain the fluid at this position. So at this point in time, there were 2 options, either a laparoscopic manipulation with a suture sling, as Dr. Crabtree mentioned, or a percutaneous manipulation with exchange of the catheter with a smaller size, probably 57 centimeter, but that is not available at the moment, but that would be the option here. So my question here would be, for this case with Dr. Crabtree, so what would be a better option for this patient? Either number 1, a laparoscopic manipulation and maintaining a suture sling, or changing the catheter with a smaller size.
Okay,
that's all
so
from my side.
By the way, those were excellent pictures and a nice demonstration of the case. That was good. And you're right. I think there's a discrepancy between the catheter size and the size of the patient, and that's why you were having some of the problems. So even though the catheter tip was in the pelvis, you noticed that it was somewhat effaced in the pelvis, which to me would indicate that it's probably too deep in the pelvis. And again, I think it's because of the catheter size and the patient's short stature. The other thing too is, on a couple of slides, it did show some fecal modeling. So I think that perhaps also some constipation issues were contributing to it. So there's a combined situation.
So in the first case, the patient was constipated.
Yeah. Right. So it's a combination of things. They both work together to cause the catheter dysfunction. So the advantage of using a suture sling is that if you do it laparoscopically, the patient can continue PD immediately postoperatively using low volume recumbent exchanges, because the surgeon can usually close the laparoscopic port sites watertight. And then so you've avoided the problems of having pericatheter leaks and what, because you're maintaining the same catheter. If the catheter, however, is too long, which this one may be, it may be better to go ahead and do a catheter exchange. And when I say catheter exchange, you essentially implant it on the other side. I would not attempt to try to put it through the same holes in the abdominal wall. I would just go to the other side, properly put the catheter, determining the proper insertion site for the catheter. So that's probably what I would try to do.
Okay.
I see a point here. Can we place it higher up? And that's exactly what we're talking about when we place it higher up. Is that yeah, you can use that 62 centimeter catheter. You would line your coiled tip with the upper border of the pubic symphysis, and with a catheter lying in the perimedian plane, you would mark the upper border of the deep cuff, and that's where the insertion incision would be made. And many times it may be actually above the level of the umbilicus. With a catheter being implanted too deep in the pelvis, it does make it more susceptible to problems like constipation, of course. The other thing that we sometimes don't think about is in older men, of course, with prostatic hypertrophy, they can have increased residual urine volume that can also compress the catheter. So on occasion, we will see an enlarged bladder producing the same problem that constipation would be, by trapping the catheter behind the bladder, a distended bladder.
So while we are having these difficulties in catheters, is it okay to just chop off some portion of it? But I think in terms of the 63 centimeter, 62 centimeter catheter that we have, if it is coiled, even if we cut it out, the whole length will be still there. So it will only be possible if this is a straight catheter. Is it right?
Yeah, so the problem of cutting off the catheter is that if you look at next time you take a look at your catheter, notice that the tip of the catheter has kind of a whistle tip. And that's made to try to make it relatively atraumatic to the visceral structures. And if you cut it off, if you transect the catheter, you kind of lose that smooth end of the catheter. So that could be a problem. I think it's better to see if you can access a catheter that's shorter in length, or as we talked about, adjusting your insertion site to account for the extra length of the catheter in smaller patients.
So what you're saying is we can put the inner cuff can be above the umbilicus?
Oh yes, many times when I align the catheter on the abdominal wall to implant it, my insertion incision is either equal with the umbilicus or even above it in many patients, especially the smaller female patients or petite patients. Your insertion site, or even obese patients who have a drooping pannus. A lot of times your insertion site may almost be in the epigastric region.
I see.
Well, if I may ask the question, sir.
Please go ahead.
It's easy for a surgeon who is having the luxury of putting a sling in there to put a catheter higher up. Is it true for the same for an interventional nephrologist who cannot do that? If he places the catheter just higher up, will it make it more probable for the catheter to move around?
Well, you still want you still, you know, whether it's you're inserting it below the level of the umbilicus or above the level of the umbilicus, the way you pass it through the abdominal wall should be the same. So I know the amount of intraperitoneal portion will also be the same. What I would do to try to keep it from moving around those especially if you have access to ultrasound, you can use it to help direct your needle through a short rectus sheath tunnel that will minimize the amount of moving around that it can do. And I know that our interventional nephrologist who just presented that excellent case does use ultrasound and fluoroscopy. I'm wondering if he is doing a little bit of rectus sheath tunneling with his initial needle insertion.
Okay. Yes, please.
Yeah,
Dr.
no.
Yu.
So I'm not doing any rectus sheath tunneling at the moment. So in my experience, you know, the approach that you guys use, the paraumbilical approach, that's a bit more traumatic as far as the percutaneous approach is concerned. So the paraumbilical or the rectus muscle tunneling, that is excellent as far as, you know, if you're inserting the catheter laparoscopically or surgically. But as far as intervention nephrologists are concerned, that's, you know, a bit too risky for us because it predisposes to more bleeding, more risky
Yeah, so
for us. So we would tend to limit ourselves to infraumbilical.
Yeah. So anyway, with ultrasound guidance, you can usually get anywhere to 2 or 3 centimeter tunnel. That still helps. If you're concerned about going through the body of the rectus muscle and sheath, maybe looking at getting a Varus type needle, one of the reusables that has an end hole on it. Teleflex Medical, which I think does have would be available from Pakistan because they are in Europe and the Middle East. You can get reusable Varus needles with an end hole that'll accept a guide wire, and that would be a lot safer way of passing that initial needle through the rectus muscle and sheath to minimize any risk of bleeding. And you can still, it's 2 millimeters in diameter for something that you could actually see with the ultrasound. And then since it's reusable, it keeps the cost.
Okay, I think Ahad's microphone is somewhere in jeopardy right now. So what we'll do is, so that happens with technology. So I think we are coming to the end of the webinar. I would request you, sir, to kindly summarize a few points, and then we can thank you goodbye.
Well, I want to thank you all for inviting me. These were interesting cases that we discussed. I thought the presentations were very well. They certainly outlined the most common problems that we have to deal with. I think the important thing that we have to think about from these 3 cases is making sure that we select the most appropriate catheter for the patient and the insertion sites, that we don't run into problems with the catheter being too deep in the pelvis. And then, the things like using heparin to prevent the clots in the catheter, reduce the risk of the clots in the catheter. And also, again, paying attention to the bowel prep or constipation issues that can contribute to the problems. So I think those are the major things that you were able to bring up with our case presentations.
Thank you very much, sir. And I would like to thank on behalf of the Pakistan Society of Nephrology, Pakistan PD Academy, and it was an honor having you on this webinar. And I will be very glad to have you again if you have time in the future also. I think we have still a lot to learn. And as we are going through this thing, I think this is going to be an easy path for us with your help. And our surgeons are here also, and that's a good sign that we all want to learn and overcome these issues for the safety of our patients and for the care of the patients. Thank you so much, sir.
Yeah, and I certainly admire your group being here together for the Academy. It was my pleasure to be here with you. Thank you again for inviting me.
Thank you very much, everyone. Thank you.
Okay, goodbye, everyone.